obviously, transport is an area in which people really know that they make a difference. And I think the advanced training that we offer to our clinicians, whether they're respiratory therapists, nurses, or indeed physicians that come and work here at Sick Kids, really attracts people to come and join the team. It's often perceived as the jewel in the crown of the neonatology program. The recognition that the work we do here would not be of any great advantage if we did not have the type of sophisticated mobile intensive care unit to bring to the patient when they're born in the community setting, I think does really attract people to want to be part of the team. And so over the years we have trained a lot of people. They're not necessarily always part of the team, but they come and they get education with us. They go out on transports, provides them with the opportunity to utilize their skills really at the cutting edge of medicine and intensive care. The biggest challenge is the fact that we have to carry out neonatal transport. There's no question that the best way to transport a baby is in utero before it's born. And there's no question we have some work to do in the area of high-risk maternal transport. We need a system for high-risk mums that is more robust, more sophisticated, more responsive to their needs, so that the baby can actually be transported before it's born, in utero, with the mum. And I think therein lies another problem, and that is that we still appear to have a significant limitation on tertiary capacity. And so very frequently when high-risk mums are identified with threatened preterm labor, or indeed a mum who's known to have problems, medical problems, who may require tertiary care herself, it's often a challenge to get that mum into a tertiary facility, and so she may very well end up delivering in the community setting, where the outcome for her baby is never going to be as good as it is in a tertiary perinatal setting, such as Sunnybrook or Mount Sinai Hospital, of course. And I think the biggest challenge lies right there. There's no question the mortality rates and the morbidity rates for babies that are born in the community outside of a tertiary setting are much higher. And despite the sophistication of the mobile intensive care unit, that is the neonatal transport team, we cannot mimic the care provided immediately following delivery in a tertiary setting. I think that's probably still our biggest challenge. On top of that, we do have challenges of being able to provide the level of sophisticated technology that we have at the bedside in the NICU, in a tertiary NICU, in transport. Our equipment is still fairly basic. You'll see one of the decks here behind me. We still have limited ability to ventilate appropriately. We still have issues of humidification. We still have issues of weight. We still have issues of lifting because of the equipment being so heavy. It's bulky, takes up a lot of space. This can be challenging in aircraft, no matter how large your fixed-wing aircraft or helicopter may be. There's still significant limitations on space. So there's some of the problems that we face today. There will always be significant challenges when it comes to training and maintaining competencies. The sickest patients, thankfully, are relatively few and far between. And so when push comes to shove, having to take care of one of the most challenging babies, particularly in a team which is not a physician-led team, can be really quite daunting and overwhelming. And that requires a lot of extra education and continuing medical education and training, which we are obliged to do on an annual basis. We provide the team with a monthly educational day. We provide the team with annual skills workshop and scenario-based training. We do a lot of work in high-fidelity simulation to try to mimic those rare events which the team will ultimately face. But there's no question that this is an area in which you really need to be on your toes all the time. And so we haven't by any means exhausted the list of problems that we may face in transport. The very first transport team, in fact, was here at Sick Kids. Back in 1970, the helipad at the old hospital for sick children opened specifically to permit transportation of adult patients to the downtown core hospitals. At that time, there was a neonatal unit, but no transport team to provide the transportation for the sick newborn. It was Dr. Swire and his vision with Dr. Graham Chance, both neonatologists at the hospital, that began the transport program by establishing a team of nurses who were capable of advanced practice skills. And in 1972, they started their first neonatal transport program. Initially using the services of the local land ambulance for land transport. And then after a few years, in fact, 1976, was the first air transport into this hospital. And that would have been the first air transport in this province of a newborn. It was a little baby boy who was born in Sault Ste. Marie, weighing 1.3 pounds. And he and his mum were transported using a fixed-wing aircraft, Air Canada aircraft, in fact, to Sick Kids via Toronto's airport, of course. And then in 1977, we had our first helicopter transport. And that was courtesy of the Sunnybrook Base Hospital, who provided us with the vehicle. But the real expertise in transport medicine is here at the hospital. The clinicians who are trained and certified to provide transport have evolved into a highly sophisticated team. In 1998, when I took over the service, having of course worked in the service, both as a transport fellow and then as a senior staff member, I decided that we needed to embrace another healthcare profession. And so we co-opted some of our respiratory therapist colleagues onto the team. And we were the first team in Canada to have an RN-RT model of care, a collaborative practice model where both the nurses and the respiratory therapists are cross-trained to look after the babies. And of course, it wasn't long before we realized that we could expand our services beyond the newborn population. And our mandate now includes infants up to the age of 3 years of age. Tele-Health has interesting applications, in fact, in transport medicine. The majority of scenarios in which Tele-Health has benefited our patients really amount to the non-acute, non-critical consultation type of service. But even in transport medicine, there are certainly applications which I believe we have yet to explore. An obvious one would be in being able to triage our transport patients. I mean, our team, which operates, of course, 7 days a week, 24 hours a day, still has limited resources. We run 3 teams around the clock. But there are still times that patients will have to wait a number of hours before our team can reach them, either because of distance or because of competing patients. I think Tele-Health provides us an opportunity to add to the advice that we can provide on the telephone, because you get a direct connection with your patient. You have an opportunity to assess them because you have the added advantage of visual images, diagnostic images like CT scans, X-rays, laboratory findings, ECGs, and so on. can be transmitted via the Tele-Health network. And so I think it adds and provides some advantage to even transport, particularly on that front end where transport advice is so important. It's interesting you asked me about telehealth because we've developed an application on our transport system here which allows us to transmit remotely, wirelessly, information from the transport deck with patient, no matter where they are in the province of Ontario, back to the hospital here, or indeed even to my desktop at home. I can actually see the patient's visuals, I can see their vital signs, I can trend the patient's journey during stabilization by looking at the trend and vital signs over time as the transport team cares for the baby during stabilization. And this is, if you like, an application of a telehealth idea, but on the transport equipment. And if you take that same hardware and software that we have put onto our transport deck, and you put that into a community facility, you can then actually have a direct communication with the tertiary unit. And I think it adds advantage to be able to provide advice and consultation straight away as soon as the baby is born. It may even prevent us from having to go to retrieve that patient if we can provide more ready access to tertiary advice. If you were looking to start a transport team in a hospital, I would suggest that you first have to look at the patient population that you wish to serve. There's no question that leading practice would suggest a highly trained team with at least 2 healthcare professionals from different backgrounds working in a collaborative practice model. The common one, of course, is RN and RT. But of course in Europe and most of Australasia, the model would be an RN with a physician, or in the States sometimes an RN with a paramedic. It really doesn't matter what the background professional is as long as they get the appropriate training in transport medicine that could be afforded by an already established program, of course. The second thing you need to consider is as I've mentioned, the patient population. Most services will look to transport the patient population from 0 to 18 to include both newborn and pediatric critical care and acute care transports. And that is probably leading practice. There are, of course, teams that are based in NICUs which only do neonatal transport, and others based out of pediatric intensive care units that only do pediatric intensive care transports. They tend to transport smaller volumes, and they may be an appropriate response to the local needs. But most of the programs that service the larger populations would be transporting the patient population 0 to 18 with a highly sophisticated, well-trained physician-less team. There's also an absolute need to have physicians that provide online medical control that are available at all times and also have appropriate training in transport medicine. Not every physician working in an emergency room or in an NICU or PICU for that matter has the necessary experience and indeed expertise to provide the kind of care that is really mandated when you're running a program like the Sick Kids Acts team.
Hilary, I have 2 questions. Number one for the...
You can look at me
is this...
No, you would look at you.
Yeah, but go ahead and ask your question.
First, for the audience to really grasp the scope, can you tell us how many transports roughly you do per year?
Yep.
How many of them are air and how many of them would be ground?
Right. So, in terms of the utilization of our...
I'm sorry, if you could try to...
In terms of the utilization of our team here at Sick Kids, the Acute Care Transport Services team that services the population 0 to 3 years of age carries out approximately 1,500 transports a year. Now, 800 or thereabouts of those transports are what we call extramural, meaning they are truly transports outside of the hospital. But within a facility like Sick Kids, where we're caring for some of the sickest patients that require transportation within the hospital, we also recognize the absolute need to provide a transport service. So my team is carrying out approximately 500 of those transports each year. And bear in mind that they're often the most unstable, the most critical of the patient population. They may have to go to the operating room or to the image-guided therapy suite, where the transport team is going to be responsible for their sedation, their anesthetic, and their care throughout the procedure. And so we have a combined intramural and extramural program that really does keep us busy.